Good morning. My name is Captain Hillary Darrow. I'm a PGY2 over here at Fort Hood, Texas. This case and presentation was prepared in partnership with Captain Megan Montessori of PGY3 of the OBGYN residency at Fort Sam Houston. Today I'll be discussing spontaneous coronary artery dissection, better known as Scad. This topic is of increasing importance in the setting of contemporary literature, which demonstrates as high as 2 to 4% of ACS is later identified to be secondary to Scad. The case presented here is that of a 34-year-old, otherwise healthy, recently separated soldier who presented 14 days postpartum with a centralized burning sensation. She was found to have nonspecific EKG changes, an elevated trope, an inpatient coronary angiogram, which demonstrated 2 areas of Scad, one in the LAD and one in the RCA. The patient was treated with labetalol and aspirin at time of discharge, along with strict exercise restrictions. The patient's follow-up imaging at 35 days following initial insult demonstrated spontaneous resolution of both lesions, which is consistent with the greater literature. The learning points for this case for both myself and those involved in the patient's care predominantly centered on the key clinical components and their similarities and differences from atherosclerotic disease. In atherosclerotic conditions, we think about the male sex and comorbidities such as hypertension, diabetes, and obesity. In Scad, we are predominantly thinking about the female sex, the peripartum period. Emotional and physical stress and isometric exercise are almost universally seen in the 24 hours preceding presentation. Early intervention in atherosclerosis often involves early heparinization. However, in Scad, the risk of early heparinization is worsening of the stenosis through worsening of the developing interluminal hematoma and should be avoided. Medical management at time of discharge for atherosclerosis is a well-known recipe. However, in Scad, only beta blocker and aspirin have been supported by clinical evidence, and ACE should only be used if left ventricular dysfunction is persistent at time of discharge. Lifestyle modifications regarding atherosclerosis predominantly center around controlling comorbid conditions, whereas Scad predominantly focuses on exercise restrictions. It is these exercise restrictions that lead us to the conclusion that early identification of Scad in active duty patients is paramount as operational implications are abundant. Thank you for your time, and I look forward to your questions, and enjoy the rest of your time at USAFP. Thank you.